All right, let's get started with ModernMedics. Ever feel like medicine has its own secret language?
You need a decoder ring just to understand the basics.
Definitely. It can be a bit overwhelming, especially when you're first starting out.
Right. But today we're tackling one of those big, kind of scary sounding topics, and we're going to break it down so it's crystal clear. No medical jargon overload, promise. We're talking about hyponatremia.
Exactly. We're going deep on hyponatremia, which really boils down to having too little sodium in your blood. Specifically, when your serum sodium concentration dips below that 135 milliequivalents per liter mark, or if you're looking at it in millimoles per liter, which is more common these days, it's the same idea, just a different unit. And, labs can have slightly different ranges, but that 135, that's the number to remember.
And it might seem like a super specific thing, but hyponatremia, it's actually the most common electrolyte problem out there, especially in hospitals and with older folks. It pops up all the time.
Oh, yeah, it's everywhere. And the thing is, it's not just a number on the lab report. Hyponatremia, it really matters. It's linked to worse outcomes with all sorts of conditions. Think liver cirrhosis, heart failure, even pneumonia. And studies show can increase the risk of both getting sick and dying. So yeah, we really got to get this one right.
Totally. So if you're listening and you're studying for the USMLEs, ABIM, MRCP, any of those big exams, especially if you're looking at material from the last 10 years, hyponatremia, it's going to be there. It comes up constantly. High yield stuff,
Absolutely.
Yeah.
And it's not just about passing exams either. This stuff has real world consequences. If sodium gets too low, you're talking seizures, even a scary condition called central pontine myelinolysis, or ODS, if we try to correct chronic hyponatremia too aggressively. It's a delicate balance.
No kidding. So in this deep dive, we're covering it all. First up, the physiology. How does sodium even work in the body? How's it regulated? Then we'll hit the different causes of hyponatremia, and we'll categorize them based on fluid status, so whether someone's volume depleted, normal, or overloaded. We'll talk about what you actually see in patients, the symptoms and signs, the tests you need to run, how to use those algorithms to nail the diagnosis, and of course, how to treat it. Different strategies, some basic dose calculations, the practical stuff. Plus, we'll touch on complications like ODS and those classic exam traps and clinical pearls, the things that can really trip you up or save the day,
Sounds good. So let's kick things off with the basics. What is sodium, and how do our bodies keep its levels in check? So we said normal serum sodium is usually between 135 and 145 milliequivalents per liter. And sodium, it's the main positively charged ion hanging out outside our cells.
Right. It's like the party's happening outside the cell, and sodium's the main guest, but it's not just waltzing in and out, right?
Nope. Sodium, it attracts water molecules like crazy, so it's actually pretty big and bulky, and needs special pathways to cross the cell membrane. Think channels or pumps, not just slipping through the cracks like some smaller ions.
Gotcha. So it's picky about its entrances and exits. And what's its main gig? Why do we even care about sodium?
Osmoregulation. Basically, making sure there's the right amount of water inside and outside our cells. And it's huge for controlling cell volume, especially in those cells that use electricity, like nerves and muscles. And the maestro of this whole sodium symphony, it's antidiuretic hormone, ADH, or you might know it as vasopressin. Comes from the posterior pituitary gland, and it's all about keeping your water balance in check.
Okay, so ADH is the conductor. What makes it decide to step in and adjust things?
Serum osmolality. It's basically how concentrated the stuff in your blood is. When that gets too high, above 295 millismoles per kilogram or so, sensors in your hypothalamus, these little guys called osmoreceptors, they pick up on that and tell the posterior pituitary to release ADH.
Okay, so the blood's getting too concentrated, ADH steps in. What does it actually do? How does that lower the sodium?
Well, ADH, it travels through the bloodstream and latches onto these receptors called V2 receptors. They're on the side of kidney cells that faces the blood. And when ADH binds, it kicks off this whole chain reaction inside the cell, increases a signaling molecule called CAN-MP, and activates an enzyme called protein kinase A.
Okay, so things are getting pretty complex inside the cell now. CMP, protein kinase A, what do they actually do?
They get those water channels ready. Specifically, aquaporin 2 channels. These guys get inserted into the side of the cell that faces the urine. So basically, they're like little pores that let water flow more easily from the kidneys back into the bloodstream.
So ADH is telling the kidneys, hey, hold on to that water, put it back in the blood.
Exactly. And by reabsorbing more water, you dilute the sodium concentration, bringing that serum osmolality back down. It's a pretty neat feedback loop. But there's a catch. ADH, it's not just about serum osmolality. Other things can trigger it too.
Right, I remember learning about that. What else can make ADH go up?
Well, if you lose a lot of blood volume, like with bleeding or severe dehydration, that can trigger ADH release even if the serum osmolality isn't that high. Nausea is another big one. And tons of meds can mess with ADH regulation and make it go up.
Okay, so lots of factors can play into ADH release, but let's say we've got a patient with low sodium confirmed by a blood test. Next step, we check their serum osmolality, right?
Exactly.
Yeah.
Serum osmolality, remember, it tells us how concentrated the blood is. Normal is usually between 280 and 295 milliosmoles per kilogram. And this helps us figure out what type of hyponatremia we're dealing with.
So what are the main categories based on that osmolality number?
The big one is hypotonic hypernatremia. True hyponatremia, some folks call it. That's when your serum osmolality is low, below 280, meaning there's relatively more water than stuff dissolved in it. It's the most common type and the one we'll focus on most today.
Hypotonic, low osmolality, got it. What else is there?
Hypertonic hyponatremia. Here, the osmolality is actually high, above 295, even though sodium's low. This usually happens when there's something else in the blood pulling water out of the cells and into the bloodstream, diluting the sodium. Like in uncontrolled diabetes, if you have sky-high glucose, that can do it.
So high blood sugar, it's like a water magnet. Makes sense. And the last category,
Isotonic hyponatremia. Normal osmolality, but still low sodium. A lot of times, this is just a lab error, what we call pseudohyponatremia.
pseudohyponatremia, so a fake out low reading. How does that happen?
Sometimes it's because there's a ton of lipids or proteins in the blood. Big molecules, they take up space in the sample. And some older lab tests, the ones that dilute the sample before measuring sodium, they get thrown off by that. So the sodium in the water part of the blood is actually normal, but the overall measurement is diluted. Newer methods, they measure it directly and don't have that problem. So yeah, good to know what kind of tests your lab uses.
For sure. Okay, so we figured out it's hypotonic hyponatremia. What's the next big clue we need to find to figure out what's causing it? I know the patient's volume status is super important.
Right on. With hypotonic hyponatremia, the next thing we got to do is assess volume status. Is the patient hypovolemic, low volume, euvolemic, normal volume, or hypervolemic, high volume? That's going to help us narrow down the possibilities. This is a big decision point, especially for exams.
And that volume assessment, it's based on history and physical exam, right? What exactly are we looking for with each of those, hypo, U, and hypervolemic?
Okay, let's start with hypovolemic hyponatremia. Here, the person's lost both sodium and water, but they've lost more sodium, or their body's holding onto water extra tight because it's low on volume, and that leads to the low sodium concentration.
So what are some of the usual suspects, the things that cause this whole hypovolemic picture?
Think about anything that makes you lose fluids. Vomiting, diarrhea, sweating like crazy, especially if they're not replacing those fluids. Diuretics can do it too, especially the strong ones we give IV, like furosemide. And remember, when you're low on volume, your body freaks out and releases ADH to try and hold on to water, which just makes the sodium dilution worse.
Makes sense. And on exam, what tells you someone's probably hypovolemic, dehydrated?
Well, they might have a dry mouth, their mucous membranes are dry, skin turgor is off. So if you pinch their skin, it stays tented up longer than it should. And sometimes you see a fast heart rate or their blood pressure drops when they stand up. Classic orthostatic hypotension.
Gotcha. So that's low volume. What about euvolemic hyponatremia? Normal volume, but sodium's still low.
Right. In this case, the total amount of water in their body goes up, but the total amount of sodium stays pretty much the same. So you get dilution. And these folks, they don't always have obvious signs of fluid overload or dehydration, which can make it tricky.
Sneaky. And what's the most common culprit in this euvolemic category?
SIADH, syndrome of inappropriate antidiuretic hormone secretion. Huge one for exams.
SIADH, yeah, that name comes up a lot. What are the key features, the things that scream SIADH?
The main thing is ADH is high when it shouldn't be. It's like it didn't get the memo that sodium's low and volume's normal. So the kidneys just keep holding on to water.
Yeah.
You end up with concentrated urine, high urine osmolality, usually over 100 million moles per kilogram, even though serum sodium's low. And because the body's not activating its usual blood pressure and fluid balance system, the RAAS system, the urine sodium is often high too, above 20 milliequivalents per liter. The kidneys aren't trying to conserve sodium.
Low serum sodium, concentrated urine, high urine sodium. Anything else in the basic labs that might point to SIADH?
Yeah, a couple of things. Serum uric acid is usually low, under 4 milligrams per deciliter. And BUN, blood urea nitrogen, that's often low too, less than 5, although that one's not as reliable in older folks. It's all because of the water retention and increased uric acid excretion. We can also calculate the fractional excretion of urate or furate, which is usually high, more than 10%, in SIADH.
Oh, SIADH is all about ADH doing its thing when it's not supposed to. What are some of the things that can cause it? Another important list for exams, I bet.
Yeah, get ready, because the list is long. Certain cancers, especially small cell lung cancer, they can make ADH on their own, ectopic production, we call it. And then there's a ton of meds, SSRIs, the tricyclic antidepressants, think of alkaloids like vincristine, cyclophosphamide, dopamine agonists, opioids, thiazide diuretics, NSAIDs, carbamazepine, oxytocin, even MDMA, pulmonary problems like TB, pneumonia, even asthma can do it. CNS stuff too, strokes, bleeds, infections like meningitis, head trauma, all on the list. Even pain and nausea can trigger ADH release. After pituitary surgery, sometimes you get a temporary SIADH, part of that triple phase response. HIV, AIDS, super intense exercise, and sometimes just plain old aging can be linked to it. And if you ruled everything out and still can't find a cause, that's idiopathic SIADH.
Wow, that's a lot to remember. Any other conditions that can cause euvolemic hyponatremia? We got to be able to tell them apart, right?
Yeah, another one to know is primary polydipsia. That's basically when someone drinks way too much water, like way too much. It overwhelms the kidneys, and even though ADH gets suppressed, it's not always enough. So you end up with dilute urine, low urine osmolality, usually under 100, and low urine sodium because the body's trying to hang on to some sodium. Totally different from SIADH, where urine is concentrated.
So urine osmolality is the key there.
Right.
Low in primary polydipsia, high in SIADH. What else falls under this euvolemic umbrella?
Low fluid intake. Classic examples, beer potomania. People drink tons of beer, which is mostly water, very little sodium or protein, and they often don't eat much else either. So you get a similar picture to a tea and toast diet. Super low sodium and protein. Not enough solutes means the kidneys can't get rid of free water effectively, so sodium goes down. Urine osmolality is low, usually under 100, and there's hardly any urea in the urine. Urine sodium can be low or high, depends on how much the RAS system is kicking in.
Okay, low solutes equal water retention. What about those endocrine disorders? Can they cause euvolemic hyponatremia too?
You bet. Adrenal insufficiency, for example. That's when your adrenal glands aren't making enough cortisol or aldosterone. Low cortisol can bump up ADH. Low aldosterone, your kidneys can't hold on to sodium. And if both are low, you might even become hypovolemic. A big clue here is high potassium hyperkalemia. That makes you think aldosterone is probably low. So you check a morning cortisol, maybe do an ACTH stimulation test. And rarely, severe hypothyroidism can cause hyponatremia too. Not totally clear why, but it might be something about lower cardiac output triggering ADH release. So you'd want to check TSH and free T4 to rule that out.
Earlier you mentioned something called osmotic reset. What's the deal with that?
Well, people used to think it was its own subtype of SIADH. The idea was that the body's set point for ADH release, that osmotic threshold, was somehow reset to a lower level. But nowadays, the thinking's changing. It might not be its own thing, more like a variation within SIADH or other regulatory mechanisms. For practical purposes, and definitely for exams, sticking to the well-established categories like classic SIADH and the other causes of euvolemic hyponatremia, that's usually good enough.
Okay, good to know. Now let's switch gears and talk about CSW, cerebral salt wasting. Where does this one fit in?
CSW usually comes up after some kind of CNS problem. Think subarachnoid hemorrhage, brain injury, or brain surgery. What happens is the kidneys start dumping sodium like crazy, natriuresis. That drops the fluid volume outside the cells, leading to hypovolemia.
So historically, the way to tell CSW, apart from SIADH, was by volume status. CSW was hypovolemic, SIADH was euvolemic. But I've heard that judging volume status just by looking at someone can be tough, not always accurate.
Yeah, that's super important to understand, especially for exams. In the past, volume status was the key difference. But now we know that just looking at someone and trying to guess their volume status, it can be really misleading. Both SIADH and CSW, they can show up with low sodium, concentrated urine, and high urine sodium, all without obvious signs of fluid overload. And they could both have low uric acid and high furate.
So if they look so similar on exam and basic labs, how can we be sure which is which? Seems pretty important for treatment, right?
The furate, it can actually help us here. In CSW, that furate, it often stays high, even after you give them IV fluids to try and fix the low volume. But with SIADH, once you correct the low sodium by restricting fluids, the furate usually goes back to normal. And this difference is key because the treatments are opposite. With CSW, you got to replace both salt and water, usually with normal saline. But with SIADH, fluid restriction is the main thing. Mixing those up, Treating CSW like SIADH and restricting fluids, that can actually be really dangerous, especially in folks with brain problems. So yeah, this is a major clinical pearl. Wow. So a small difference in the lab can mean a huge difference in how you manage it.
Yeah.
Okay, last one. Hypervolemic hyponatremia. We touched on it briefly before. Right. So with hypervolemic hyponatremia, you have more total body sodium, but the total body water, it's increased even more. So again, dilution. And the crazy thing is, even though there's extra fluid overall, the amount that's actually circulating effectively and reaching the organs, that can be low. So the body thinks it needs to hold on to water, releases ADH, and the kidneys try to conserve both sodium and water. But the water retention wins out.
And what are the typical scenarios where we see this kind of hyponatremia?
Think heart failure that's not well controlled, advanced liver cirrhosis with ascites, nephrotic syndrome where you're losing protein in the urine and getting fluid shifts. You often see swelling in the legs, ascites, other signs that there's too much fluid overall. And with hypervolemic hyponatremia, urine sodium is usually low, under 20, because the kidneys are trying to hold on to sodium, even though overall there's too much.
Okay, so we've got our hypo, OU, and hypervolemic hyponatremia all sorted out. Now let's talk about how this actually looks in patients. What are the symptoms and signs that low sodium causes?
The clinical picture, it really depends on how low the sodium is, and even more importantly, how fast it dropped. If it's acute hyponatremia, meaning it went down quickly, you're way more likely to see obvious symptoms compared to a slow, gradual decline. This acute versus chronic distinction, it's huge for understanding what's going on and figuring out the treatment.
So if someone has mild hyponatremia, let's say their sodium is between 130 and 134, what might we see?
Honestly, they might have zero symptoms. They feel totally fine, and it's only picked up on routine labs.
Okay, what about if it goes a bit lower, like down into the 120s?
That's when things start to get noticeable. Headache, nausea, feeling tired or sluggish, maybe some muscle cramps. They might have trouble walking, feel unsteady, which can lead to falls. And some studies even suggest that even mild to moderate hyponatremia that's been there a while, it can cause subtle problems with thinking and attention. And long term, there might even be a link to osteoporosis and broken bones. So yeah, even if it seems mild and it's been going on a while, it's still important.
Huh, that's interesting. I didn't realize it could have such broad effects, even when it's not super severe. What about if it dips below 120, or if it drops really fast no matter what the number is?
That's when you got to worry. You can see confusion, disorientation, seizures, coma, even brain swelling, because the low sodium outside the cells makes water rush into the brain. And that rapid swelling, that's why acute hyponatremia with symptoms, that's a true emergency.
So it's the quick drops that really cause those big neurological problems because of all the water shifting into the brain. What about the physical exam? What are we looking for specifically, keeping in mind the different volume statuses?
Well, with hypervolemic hyponatremia, you'll see those signs of fluid overload we talked about, swollen legs and ankles, bulging neck veins, ascites, maybe even fluid in the lungs. You'd hear crackles when you listen with a stethoscope. Hypovolemic, you're looking for the dehydration signs, dry mouth, that tinted skin. But with euvolemic hyponatremia, it can be tough. You might not see any obvious signs of either too much or too little fluid. So paying close attention to the neuro exam, looking for even subtle changes in mental status, that can be key. And always think about their other medical problems. If they have heart failure or liver disease, that gives you more context. Right, the whole picture matters. Okay, we've covered the clinical stuff. Now, how do we investigate and diagnose hyponatremia? What's the step-by-step process? This is important stuff for exams. First things first, you got to accurately measure that serum sodium. And ideally, you want your lab to use an ion-selective electrode with direct potentiometry. That way you avoid that pseudo-hyponatremia problem, so you know you're dealing with a real low sodium.
Okay, so we confirm the low sodium using the best method possible. What's next on our list?
Serum osmolality. Got to check it. It tells us if it's hypotonic, isotonic, or hypertonic hyponatremia. Helps us rule out those fake outs like pseudo-hyponatremia, or something else in the blood is messing with the sodium, like high glucose. And while you can calculate osmolality, measuring it directly is better, especially if you think there might be other stuff contributing. But if you can't get a measured osmolality, there are formulas you can use to adjust for really high glucose, triglycerides, or proteins. Like a good rule of thumb is for every 100 milligrams per deciliter increase in glucose above normal, you might see sodium drop by about 1.6 to 2.4 milliequivalents per liter.
So we got to account for those other things floating around in the blood. Step 3, we assess volume status, like we talked about.
Yeah, history, physical exam, the whole 9 yards, hypovolemic, euvolemic, or hypervolemic. Super important decision point.
And after volume status, what's our next lab test?
Urine osmolality. This tells us if ADH is doing its thing or not. Low urine osmolality, under 100, means ADH is probably low. Think primary polydipsia, low solute intake, those kinds of things. High urine osmolality over 100 means ADH is active and holding on to water. That's what you see with SIADH, CSW, or when your body's appropriately responding to low volume.
So urine osmolality gives us a clue about ADH. What about urine sodium? What does that tell us?
Urine sodium helps us figure out if the kidneys are conserving sodium appropriately. If urine's concentrated and urine sodium's high, over 20, that means the kidneys aren't holding on to sodium like they should be. Think SIADH or CSW. But if someone's hypovolemic and urine's concentrated, you expect low urine sodium, under 20, because the RAAS system is working hard to conserve sodium.
And sometimes urine sodium alone isn't enough. That's when we break out the fractional excretion calculations, right?
Yeah, you got it. Fractional excretion of sodium, FeNA, and sometimes fractional excretion of urea, furia. Super helpful when urine sodium is not giving you a clear answer. If FeNA is less than 0.5% or furia is under 55%, chances are the RAAS system is fired up and the kidneys are holding on to every bit of sodium they can. That's what you see when someone's truly volume depleted.
FeNA, furia, more clues about what the kidneys are up to. Any other blood tests that can help us pinpoint the cause of hyponatremia?
Yep, check that serum uric acid and BUN. Low uric acid, less than 4, and low BUN, less than 5. But remember, BUN can be tricky in older people. That can support an SIADH diagnosis. It's all about the water retention and increased uric acid excretion. And the furate, that fractional excretion of urate, it's often high in both SIADH and CSW, over 10%.
Low uric acid, low BUN. Think SIADH. What other routine blood tests should we be ordering?
Potassium's important. If it's low, hypokalemia, that could be from certain diuretics. High potassium, hyperkalemia, that makes you think adrenal insufficiency. Calcium's good to check too. And BUN and creatinine, those tell us how the kidneys are doing overall and can show us if the kidneys aren't getting enough blood flow, like in hypovolemia. We had to check TSH and free T4 to rule out hypothyroidism.
Yeah.
And if we're worried about adrenal insufficiency, especially with hypovolemic hyponatremia, low urine sodium and high potassium, checking morning cortisol and maybe doing an ACTH stim test, that's essential.
And you said the furate can help us tell SIDH and CSW apart. Can you quickly go over that again?
Sure. So both SIADH and CSW, they usually have a high furate. But the key is, in SIADH, once you correct the hyponatremia with fluid restriction, that furate tends to go back to normal. But with CSW, even after you give them saline, the furate often stays high. That can be a lifesaver when you're not sure about the volume status just from looking at the patient.
Okay, good to know. So we've talked about the tests and how we figure out what's going on. Now, the big question, how do we treat it? This is where the rubber meets the road, both in the clinic and on exams.
The main goals are to treat whatever's causing the low sodium and to be super careful about how fast we correct it. Because if we correct chronic hyponatremia too quickly, we can trigger ODS.
Right. Speed is key. What about when someone comes in with acute symptomatic hyponatremia, like their sodium tanked quickly and they're having neurological problems? That always feels high stakes.
Yeah, those are the ones that get your heart racing. If they're confused, having seizures, coma, we've got to bring that sodium up fast but carefully. We often start with a little IV push of hypertonic saline, like 100 to 150 milliliters of 3% saline over 10 to 20 minutes, then reassess. We want to raise it by 4 to 6 milliequivalents per liter in the first hour or two to get them out of immediate danger. And we're checking sodium levels constantly every 2 to 4 hours at first. The general rule is don't increase it by more than 10 to 12 millimoles per liter in the first 24 hours, and then no more than 8 to 9 millimoles per liter every 24 hours after that until it's back up to a safer level, usually around a 130. And if it's going up too fast, we got to slow it down, maybe give them some hypotonic fluid like D5W, maybe even desmopressin if it's overcorrecting from chronic hyponatremia.
So faster correction for acute cases, but still with strict limits. What about if it's mild, no symptoms?
Then we focus on treating the underlying cause. If it's SIADH, which is common, we often start with fluid restriction, usually around 800 to 1,000 milliliters per day. You can adjust that based on their sodium and how they're doing. Some folks with chronic SIADH, they might need to restrict fluids long-term, like 1,200 to 1,800 milliliters per day. And make sure they're getting enough sodium and protein in their diet, especially if it's from low solute intake. Sometimes just adding salt and protein does the trick.
And what about those volume-related hyponatremias, hypovolemic and hypervolemic? How do we tackle those?
Hypovolemic, you got to replace what they've lost. Usually IV normal saline, 0.9%. How much and how fast depends on how depleted they are and their overall condition. Hypervolemic, You got to treat the underlying problem, the heart failure, cirrhosis, nephrotic syndrome. That often means restricting fluid and sodium and giving diuretics to help get rid of excess fluid. The goal is to improve that effective circulating volume so their body doesn't feel the need to hold on to water so much.
You mentioned Tolvaptan earlier for SIADH. How does that fit into the picture?
It blocks the action of ADH in the kidneys. So you pee out more water without losing a bunch of sodium or other electrolytes. It can be a helpful drug for chronic euvolemic or hypervolemic hyponatremia, especially with SIADH, heart failure, or cirrhosis when just restricting fluids isn't enough. Usually start with 15 milligrams once a day and adjust based on response and sodium levels up to a max of 60 milligrams a day, but sometimes we start lower at 7.5 milligrams. But because it can correct sodium too quickly and there's a risk of liver problems with long-term use, over 30 days, we usually start it in the hospital so we can watch their sodium closely, every 4 to 6 hours at first, then daily. An important note, don't use it if they're hypovolemic, have liver disease, or can't make urine. And it's not our go-to for acute, severe, symptomatic hyponatremia. There, we need a faster but controlled correction.
So Tolvaptan is one tool in the toolbox. Any other meds besides that for SIADH?
Yeah, Tolvaptan blocks the V2 receptor, but there are other options. Sometimes we use loop diuretics like furosemide, along with fluid restriction to help get rid of water. Demeclocycline is another one. It's an antibiotic, but it can make the kidneys less sensitive to ADH, so they make more urine. Usual dose is 600 to 1200 milligrams a day, split into a couple of doses, but it takes a few days to kick in, and you got to watch for kidney problems, especially in folks with liver disease. And for chronic SIADH, sometimes we use oral urea. It pulls water out with it when it's excreted.
And how do we manage CSW, remembering that it's all about low volume?
Like we said, the key with CSW is to replace the sodium and water they've lost. Usually that means IV normal saline. And you got to carefully watch how much you give and how they're doing, their fluid balance, their electrolytes. And remember, fluid restriction, which is the main treatment for SIADH, would be the wrong move here. It would make the low volume worse.
And what about if we think a medication is causing the hyponatremia?
First thing, stop the med if you can. And always get a detailed med history. What are they taking? Prescription, over-the-counter, supplements, everything. If you can't stop the med, or there's no good alternative, watch their sodium like a hawk. And be aware of the common culprits, the ones known to cause hyponatremia. Thiazide diuretics, SSRIs, carbamazepine, those are some big ones.
Wow, this has been an amazing deep dive into hyponatremia. Super detailed, clinically relevant, the whole package. But let's do a quick recap of the key takeaways, especially for our listeners who are studying for exams. What are those big exam traps and clinical pearls?
All right, here's the top stuff to remember. Number 1, rate of correction, especially in chronic cases. Got to avoid ODS. Know the targets for acute and chronic. 2, don't rely too much on just looking at someone to figure out their volume status. It can be misleading. If you're stuck between SIADH and CSW, remember the Pure 8 can help you decide. 3, always think about adrenal insufficiency, especially with hypovolemic hyponatremia, low urine sodium, and high potassium. Check that morning cortisol. Think about an ACTH stim test. 4, remember pseudo-hyponatremia can happen, especially with high lipids or proteins. Know when to ask for a direct sodium measurement. 5, medication history. Can't stress this enough. 6, always interpret sodium in the context of the whole patient. How are they presenting? How long has it been going on? What other problems do they have? 7, formulas for sodium deficit. They're helpful, but treatment is based on the rate of correction, not just replacing a number. 8, got to monitor sodium levels frequently when you're actively treating it. 9, if you overcorrect chronic hyponatremia, IV desmopressin can help bring it back down.
And finally, keep those newer drugs in mind, like SGLT2 inhibitors. They can mess with sodium too.
This has been incredibly helpful. So to sum up the really big points, we talked about the definition of hyponatremia, how important it is to know the osmolality and the volume status, the major causes like SIADH, CSW, drinking too much water, not getting enough solutes, endocrine problems. We hammered home how dangerous it is to correct chronic hyponatremia too quickly and that systematic approach to diagnosing and managing it.
And to leave you with something to think about, given how many common meds can affect sodium, how often are we missing mild or chronic hyponatremia, maybe blaming the symptoms on something else? And as we learn more about SIADH and CSW, how will our approach to diagnosis and treatment change in the future?
Thanks for joining us for this episode of ModernMedics into Hyponatremia. We hope you are walking away with a clearer, more complete understanding of this complex but super important topic. If you like this episode, please subscribe, comment, and hit the like button.